स्टार्ट करेंगे प्रेगनेंसी से। प्रेगनेंसी में फिजिकल साइंस हैं, दैट्स वेरी इंपॉर्टेंट, जो कि गॉडल साइन है, चैडविक साइन एंड हैगर साइन. गॉडल साइंस इज बेसिकली softening of the cervix at the 4 to 6 week. Chadwick sign is basically at bluish discoloration of the cervix at 6 week. Hager sign is softening of the cervix at 6 to 8 weeks. Investigation we done is beta HCG positive in serum at 9-day post conception, and plasma levels usually double every 1.4 to 2 day. uh, Peaks at the 8 to 12 week gestational age, then fall but continue to be measurable until delivery. Levels less than expected can suggest ectopic pregnancy, abortion, inaccurate dates, but found in some normal pregnancies. Level greater than expected as a suggest of multiple gestation, molar pregnancy, trisomy 21, inaccurate dates, and some normal pregnancies or disease, kidney disease like slower clearance. Ultrasound. Transvaginal ultrasound is basically 5-week gestational age, gestational sac visible, 6-week gestational age, and fetal pole visible, and 6 to 8 is basically fetal heart rate activity visible. Transabdominal is done at 6 to 8 week intrauterine. Then on the side is basically be conscious of the use of the gendered language when providing reproductive care to the transgender male and the gender diverse patients. Discuss with each patient the terminology that they are most comfortable using in order to avoid gender dysphoria throughout the pregnancy care. Establish the desirability of the pregnancy in the patient with a suspected or confirmed pregnancy informs the instruction of an inappropriate management plan. Then comes beta HCG rule. Okay, beta HCG rule of tens, 10 IU at the time of missed menses, and 100,000 IU at 10-week gestational age, and then 10,000 IU at term. Trimester Tri1 is basically 1 to 14-week gestational age. T2 is 14 to 28-week gestational age. T3 is basically 28 to 42-week gestational age, and normal pregnancy term is 37 to 42-week gestational age. Then comes the maternal physiological adaptation to the pregnancy. Skin is basically increased pigmentation of the perineum and areola and the chloasma, linea alba, spinal angioma, palmar erythema due to increased estrogen levels, tria gravidum due to connective tissue changes, cardiovascular hyperdynamic circulation, increased cardiac output, heart rate, and blood volume, decreased blood pressure, decreased PVR, and decreased venous return from enlarging uterus, compressing IVC and pelvic veins. Increased venous pressure leads to the risk of varicose veins, hemorrhoids, and the leg edema. Hematological hemodilution causing physiological anemia and apparent decrease in hemoglobin and hematocrit, increased leukocyte count, but impaired functional lead to improvement in some autoimmune diseases. Gestational thrombocytopenia, mild and asymptomatic, normalizes within 2 to 12 weeks following delivery. Hypercoagulable state, increased risk of DVT and pulmonary embolism, but also decreased bleeding at delivery. Then comes the respiratory, increase incidence of the nasal congestion, increase oxygen consumption to meet increase metabolic requirements, and elevated diaphragm. Increased minute ventilation leads to decreased CO2 resuscitation in mild respiratory alkalosis that helps CO2 diffuse across the placenta from the fetal to the maternal circulation. Decrease total lung capacity, functional residual capacity, and residual volume. No change in the vital capacity and FEV1. Gastrointestinal GERD due to increased intra-abdominal pressure and progesterone. Increased incidence of gallstones due to progesterone causing increased gallstone stasis. Constipation due to progesterone causing decreased GI motility and hemorrhoid as a result of constipation and increased intra-abdominal pressure. Genitourinary increased urinary frequency due to increased total urine output. Increased incidence of UTI or pyelonephritis due to urinary stasis. Glycosuria, that can be physiological changes in the T3, considered testing for the GDM if noted in the first 2 trimesters. Ureteric and renal pelvic dilation due to progesterone induced smooth muscle relaxation and uterine enlargement. Increased CO, then increased GFR leads to decreased creatinine and uric acid and BUN. Neurological, increased incidence of carpal tunnel syndrome, sciatica, and Bell's palsy. Then comes the endocrine. Endocrine is basically moderate enlargement of the thyroid and increased basal metabolic rate. Increased total thyroxine and thyroxine binding globulin, and normal free thyroxine index and TSH level is normal. So then comes the physiological suppression of TSH in T1 is common due to the cross reactivity of HCG to TSH receptors. Then adrenal increase maternal cortisol level throughout the pregnancy, calcium decrease total calcium level due to the decreased albumin. So then comes the free ionized calcium, which is a little bit on the higher side, remains the same due to parathyroid hormone. So this says that the free ionized calcium active proportion is basically remains the same, resulting in the increased bone absorption, reabsorption, and the gut absorption and increased bone turnover, but no loss of the bone density due to estrogen inhibition. Then comes antepartum care, pre-conception counseling can be provided by obstetrician, family physician, midwife, and multidisciplinary team. So 3 to 8 week gestation is a critical period of organogenesis. So early preparation is vital. Then comes past medical history, optimize medical condition, and review medications prior to pregnancy. Supplementation, we give folic acid. Then prenatal vitamins, consider iron supplementation in T2 and T3 earlier in the cases of the iron deficiency anemia. Lifestyle modification like smoking, alcohol, drug use, some domestic violence, occupational risk, poor social support, balanced nutrition, and physical fitness. Medication, discuss teratogenicity of the medication so they can be adjusted, replaced, or stopped if necessary. Infection screening is basically rubella, HBsAg, VDRL, pap smear, gonorrhea, chlamydia, HIV, TB testing based on the travels and the working in the healthcare history of varicella or vaccination and parvovirus immunity if exposed to the small children. Genetic testing as appropriate for the high risk groups. Consider genetic referral in known carriers and recurrent pregnancy, loss, stillbirth, family members with the developmental delay, birth anomalies, and genetic diseases and consanguinity. On the side, family physician and the midwives can consider obstetrician consultation for the condition, including insulin dependent GDM, gestational diabetes mellitus, stolac, increase of and then multiple gestation, malpresentation, active antepartum hemorrhage, PTL, preterm labor, premature rupture of membrane, and premature prolonged rupture of membrane. And then comes the failure to progress, induction, augmentation if high risk, and then tier third and fourth degree, retained placenta, IUGR, and postpartum hemorrhage. In these cases, we can ask for the obstetrician consultation. Advise all patients capable of becoming pregnant to supplement their diet with 0.4 mg of the folic acid, and then it can be changed according to the need. Prenatal and the genetic screening are voluntary and require proper counseling and informed consent before proceeding. HIV screening is done automatically in some provinces as outpatient testing. Need to inform patient of this. Then comes the initial prenatal visit, in usually within 8 to 12 weeks of the first day of LMP, and earlier if less than 20 and more than 35 years. Bleeding, very nauseous, and other high risk factors present. Then comes the history, that is Nager's rule, first day of LMP plus 1 year plus 7 day into minus 3 months. LMP is basically that is calculated. EDD by the LMP not reliable if irregular menstrual period, if the patient unsure of the last menstrual period. Dating ultrasound should be offered to all the patient. EDD by the T1 ultrasound after 7 weeks more reliable than the LMP if difference is greater than the 5 day from LMP due to due date. History of the present pregnancy, bleeding, nausea, vomiting, all the previous pregnancies, past medical history, surgical and gynecological history. Prescription and non-prescription medication, have family history, diabetes, hypertension, thyroid disease, mental health issues, and then genetic disease, birth defects, multiple gestation, consanguinity. Then comes the social history, smoking, alcohol, and substance abuse, intimate partner violence, screening, look for the bruises, improbable injury, depression, late prenatal miscare, missed prenatal visits, or appropriate cancel on the short notice. In history of the previous pregnancies on the side, always ask for the GT-PAL, year, sex, weight, gestational age, mode of delivery, length of labor, and complication. Ask every woman about abuse, not just those women whose situation raise suspicious of abuse, and ask as early as possible if pregnancy. Then comes the physical exam, complete physical exam to obtain baseline patient information, BP, weight information for the interrupting subsequent or changes, BMI for the risk factors, risk of DVT, GDM, gestational diabetes mellitus, and preeclampsia, all women with the greater BMI. Then comes the investigations, blood work, CBC, blood group, and RH status, antibody screen, infection screening as per preconception counseling, urine routine, microscopic midstream urine culture and sensitivity screening for bacteriuria and proteinuria. Pelvic exam, then comes the pap smear, if only if required according to the patient history and provincial screening guidelines. Cervical or the urine PCR for the Neisseria gonorrhea and chlamydia trachomatis. On the side, estimated date of the delivery, EDD determination by LMP if mens is irregular, patient reliable historian, and by T1 ultrasound by embryo age and date of the transfer if in vitro fertilization, T1 ultrasound up to 13 plus 6 into 7, 6-7 week gestational age is most accurate testing of establishing gestational age. Changes to the EDD must be documented and discussed with the patient, and pregnancy without ultrasound confirmation or revising the EDD prior to 22 plus 7 week gestation is considered suboptimally dated. Then it says nausea and vomiting affects 50 to 90% of the pregnant women, often limited to T1 but may persist beyond this. Management: rule out any other causes of the nausea vomiting if refractory to the initial therapy. Wait frequently, assess the level of hydration and test urine for the ketones. Non-pharmacological, frequently small meals like bland, dry, salty and are well tolerated. Then encourage any safe appealing foods, electrolyte oral solutions like Pedialyte and Gatorade, and stop prenatal vitamins if T1, substitute with the folic acid or adults and children's vitamin that are low in iron. Then comes increase sleep and the rest. Then ginger maximum of 1000 mg per day, and then acupuncture, acupressure, mindfulness and based cognitive therapy. Then pharmacological, which is basically first line is pyridoxine monotherapy, or you can give doxylamine and pyridoxine combination 4 tablets per oral daily, up to maximum of 8 tablets per day. H1 receptor antagonist should be considered for acute and chronic episodes of nausea vomiting in pregnancy. Metoclopramide and phenothiazine can be used as adjuvant therapy for the sway nausea vomiting in the patient, or densitron if the sway nausea vomiting and other antiemetics have been failed. So first is pyridoxine, then we can switch to metoclopramide, H1 receptor if at heartburn, but if everything fails then we can switch on to ondansetron. Consider use if of acid reducing medication as adjuvant therapy like antacid, H2 blockers and PPIs. Sware and refractory, then we have to consider home care with IV fluids and prenatal antiemetics and hospitalization. Then comes hyperemesis gravidarum. Intractable nausea vomiting usually present at T1, then diminishes, occasionally persists throughout the pregnancy, affects almost 1% of the pregnancies. Multifactorial with the hormonal, immunological and psychological components. Rapidly rising beta ACG plus minus estrogen level can be implicated. Rule out systemic causes like gastrointestinal, pyelonephritis, and thyrotoxicosis. Rule out other obstetrical causes like multiple gestation, GTN, and then comes CBC, electrolytes, BJON, creatinine, LFTs, urine analysis, and ultrasound. So basically, we are doing everything. Then management is basically thiamine supplementation because it's going to be causing that Wernicke situation. May be indicated and non-pharmacological. Pharmacological options basically doxylamine and pyridoxine. So we're starting from the thiamine, that is basically the first pharmacological, then we're moving on to doxylamine or pyridoxine. Then comes the dimenhydrinate, can be safe, used as adjuvant to the diclactin, which is given as a suppository. Then other adjuvants is basically hydroxyzine, pyridoxine, and then phenothiazine and metoclopramide. Other considered like ondansetron and methyl prednisolone. Avoid steroids in T1 due to the increased risk of oral clefting. If severe, admit to the hospital, NPO initially, then small frequent meals, correct hypovolemia, electrolyte disturbance, ketosis, and then TPN to reserve catabolic state. Then complications is basically maternal dehydration, electrolyte and acid base disturbances, Mallory Vestier, and then Wernicke encephalopathy if protracted course. And then this death. Fetal usually none. IUGR is 15 times more common in the woman, losing like more than 5% of the pre-pregnancy women. Subsequent prenatal visit for uncomplicated pregnancies short of gestational change recommends for every 4 to 6 week gestational age until 30 week, then every 2 to 3 week from 30 week gestational age, and every 1 to 2 week from the 36th gestational week until the delivery. So in the first week we are going to do is like 4 to 6 weeks, then we are going to and shorten up like 2 to 3 weeks, and then we are going to do every 1 to 2 weeks. As that's then comes assess at the every visit estimated gestational age, history, family history, vaginal bleeding, leaking, cramping, questions or concerns, and physical exam is BP, weight gain, as symphysis fundal height, Leopold's maneuver to determine the lie position and the presentation of the fetus. Investigation is urine analysis for the proteinuria in the high risk women, hypertensive like patients. In those we get do urine analysis. Fetal heart rate starting at the 10 to 12 weeks using Doppler ultrasound. Then comes the Leopold maneuvers like performed after 30 to 32 week gestation. First maneuver to determine which fetal part is lying further away from the inlet. Then comes the second maneuver to determine the location of the fetal back. Then third maneuver in which the patient part is lying above the pelvic inlet, and the fourth to locate the patient burrow. Then it's on the side symphysis fundal height on the 12th week, the symphysis fundal height at the pubic symphysis. Then comes the 16th week, then it becomes the mid halfway of the pubic symphysis to the umbilicus. Then 20 week, which is at the level of the umbilicus, and 20 to 26 weeks symphysis fundal height should be within 2 centimeter of the gestational age. Symphysis fundal height less than dates, then the date miscalculation, IUGR, fetal demise, oligohydramnios, and early engagement, and the transverse lie. Symphysis fundal height is more than dates, then what happened is basically date miscalculation, multiple gestational age, polyhydramnios, and large for the gestational age, basically familial, diabetes mellitus, and fibroids. Then comes the prenatal screening and the diagnostic test. Screening test is testing should also occur following counseling with the informed consent from the patient. Then comes the high risk population, which is basically thalassemia, sickle cell anemia, cystic fibrosis, Tay Sachs disease, and Fragile X syndrome. So the screening test is basically in the thalassemia we do CBC, MCV, MCH, HB electrophoresis, or HPLC. Then in the sickles we do the same CBC, HB electrophoresis, and HPLC. In cystic fibrosis we do CFTR gene DNA analysis, and then we do, and the Tay Sachs is basically gene and assay for hexa and DNA analysis for X hexa. We can do anything. Then we go for Fragile X is basically DNA analysis for FMR1 gene. Then comes the gestational dependent screening investigation, which is basically at 8 to 12 we do dating ultrasound, do pap smear, chlamydia, gonorrhea testing, urine ultrasound, detect asymptomatic bacteriuria, HIV, VDRL, HBsAg, rubella IgG, parvovirus IgM if symptomatic, or IgM if high risk. Small child at the home or the daycare worker, primary teacher, varicella IgG if no history of disease, immunization, CBC, blood group, or screen. Then more than 10 week we do NIPT, non-invasive paternal testing. Then in that what we do is we check for the Meyer cell-free fetal DNA in the maternal circulation more than 10 week. Then comes 10 to 12 week, which is basically chronic villus sampling, diagnostic testing, which is it's not a screening testing. Then 11 to 14 is basically enhanced fetal test screening, or the IPS part 1. Then 11 to 14 is basically knuckle translucency ultrasound, which is used to measure the knuckle translucency on ultrasound, beta HCG, PAPPA, and then placenta growth factor, and then maternal serum alpha fetoprotein. Then is 15 to 16 to term, which is basically done for amniocentesis, that is also a diagnostic test, not a screening test. 10 to 15 to 20 is basically IBS part 2. Meyer is basically maternal serum alpha fetoprotein, beta HCG, unconjugated estrogen, and inhibin A. Then comes 15 to 20 is basically maternal serum screening. In that we measure maternal serum alpha fetoprotein, beta HCG, unconjugated estrogen, and inhibin A. 18 to 22 term is basically fetal monitoring. 18 to 20 is basically ultrasound for the fetal size, anatomy, and assessment and placement location. Then comes is basically 24 to 28, which is basically done for the diabetic screening, gestational diabetic screening by doing OGCT 50 gram. Then comes 28 is basically repeat CBC plus minus ferritin, RHIG for all RH negative women, and then 35 to 37 is basically GBS screen. Then 6 week postpartum, and then we do discuss contraception, menses, breastfeeding, depression, mental health, support physical exam like breast exam, pelvic exam, including pap smear, wound assessment, perineum or C-section scar. Then on the side is basically written for the routine 2. Ultrasound at 18 to 20 week gestational age helps to determine number of fetuses. And then gestational age, if no prior ultrasound, location of the placenta and fetal anomalies. Diagnosis of increased maternal serum alpha fetoprotein is basically incorrect. Gestational age, more than one fetus, fetus loss, or more important is open neural tube defect or abdominal wall defect, which is basically omphalocele. So it shows, what it shows is basically fetal loss, open neural tube defect, and is basically abdominal wall defect. Then comes the ultrasound screening. 8 to 12 week dating ultrasound, most accurate form of the pregnancy dating. Measurement of the crown rump length, margin of the error plus minus 5 day. EDT should be based on the T1 ultrasound if available. 11 to 14 week gestational age ultrasound for the anti measurement. Measure the amount of the fluid behind the back of the fetus. Early screen for the trisomy 21 may also detect cardiac anomalies and other aneuploidies like Turner syndrome. Neural tube defect, neural tube is knuckle translucency is measured for the FTS and IPS part 1, 18 to 20 week. Growth and the anatomy ultrasound is done, and earlier or subsequent ultrasound performed when medically indicated. Non-invasive prenatal NIPT, basic prenatal testing and analysis, maternal blood for the circulation cell-free DNA at the 10-week gestational age onwards requires dating ultrasound for accuracy. So on the advantages we can check is basically trisomy 21, trisomy 18, Turner syndrome, and other defects like D. George, Cree-Duke, Chat, and Prader-Willi, Angelman syndrome, XY syndrome. And then we can also earlier timing with the results available in 1 to 2 week, when parents can potentially have a chronic villus sampling in 10 to 12 week for diagnosis over an amniocentesis after 15 week. Then comes the disadvantages: does not screen for oral neural tube defect, cannot covered by most provincial health insurance system, need to confirm the invasive testing, like basically we need to do chronic villus sampling or amniocentesis, whatever required. Obtain a result defect depend on the sufficient fetal fraction, and does not test for all aneuploidies, and gives not result in 1 to 5% of the cases, like insufficient fetal fraction, and most common with elevated BMI. Then comes the comparison FTS, MSS, and IPS. In those we have to remember the time, like 11 to 14 week gestational age. MSS maternal serum screening we do at 15 to 20 week, and IPS can be done at 11 to 14 week for ultrasound knuckle translucency, 11 to 14 week for fetal tissue screening, and then 15 to 20 is basically maternal serum screening. What happens in FTS? Down syndrome, trisomy 18. In Down syndrome, what we check is increased knuckle translucency, increased beta HCG, and decreased PAPPA. And then trisomy 18, increased knuckle translucency, decreased PAPP. And then maternal serum screening, ONTD, open neural tube defect, increased maternal serum alpha fetoprotein. And trisomy 21, decreased maternal serum alpha protein, and increased beta HCG, and decreased UE3, mu-E3. Then trisomy 18, decrease maternal serum alpha fetoprotein, and decrease beta HCG, and decrease mu-E3, and decrease inhibin A. Then IPS is basically risk estimated for open neural tube defect, trisomy 12, 18, and sensitivity is very high, 2% false negative. Patient with a positive screen should be offered ultrasound and amniocentesis or NIPT, which is basically covered in most of the provinces. And in the FTS, useful when the patient wants like results within T1, most accurate estimated of the Down syndrome, because we can check the knuckle translucency and we can get to know about that. Risk then the maternal serum screening. Sensitivity is very good. Patient with a positive screen should be offered CVS, amniocentesis, and NIPT. Then comes the maternal serum only offered alone if the patient missed the time of the IPS and FTS. So 8% baseline false positive for the trisomy 21, lower for the knuckle translucency, like neural tube defect, and patient with a positive screen should be offered with the ultrasound, amniocentesis, and NIPT. Then comes the diagnostic test, which is two, like amniocentesis and chronic villus sampling. The indication is basically age more than 35, risk factors in the current pregnancy, abnormal ultrasound, abnormal prenatal screen like IPS, FTS, MMS, and NIPT. past history, family history of the chromosomal anomalies or the genetic disease, either parent or known carrier of the genetic disorder, or a balanced translocation, consanguinity, more than 3 spontaneous abortion. Then comes the amniocentesis, ultrasound guided transabdominal extraction of the amniotic fluid performed as early as 15-week gestational age. Then comes the indications of the genetic and the chromosomal anomalies. 15 to 16 week gestational age as per indication above, confirmation of the positive NIPT testing, and then positive FTS, IPS, MMS, and assessment of the fetal lung maturity via the LS ratio, lesser than like swinging ratio. Then if more than 2 to 1 ratio, RDS is less likely to occur. Then advantages is basically also screen for the open neural tube defect, 96% accurate in the woman more than 35 year. The risk of the chromosomal anomaly is greater than the risk of the miscarriage from the procedure. More accurate genetic testing than the CVS. Disadvantages basically it's like a risk of a procedure related pregnancy loss, and then local experience, and then results after like 14 to 28 day. Then is basically disadvantages, and then results that 14 to 28 week or fish PCR or fish can be done on the chromosome XY 13, 18, 21, 22 to give preliminary results in 48-hour chromosomal microarray, also readily available. Then comes on the side, compared to CVS, amniocentesis has a higher accuracy of prenatal cytogenicity diagnosis and the lower risk of spontaneous abortion. Then is risk factors of the for the neural tube defects like GRIM, genetic, race, insufficient vitamins, maternal chronic disease, and maternal use of anti-epileptic drugs. Then it comes as genetic, family history of neural tube defect, risk of having second child with a neural tube defect is increased of like 2 to 5%. Consanguinity is basically trisomy 13, 18, and 21. Race is basically higher risk in the European and the non-Hispanic whites than African American, and 3 like basically it happens more in European and like non-Hispanic wine than the African, and threefold in the Hispanic. And then insufficient like vitamins, basically zinc and folate. Then comes is maternal chronic disease by like diabetes mellitus, and maternal use of anti-epileptic drug. General population risk of neural tube defect is like 0.1%. That's not even too much. Chronic villus sampling is basically biopsy of the fetal derived chorion using a transabdominal needle or transcervical catheter at 10 to 12 week gestational age. Then advantages, then enables pregnancy to be terminated earlier than with the amniocentesis, rapid karyotyping, and the biochemical assay within 48 hours using fish analysis. High sensitivity and specificity. Then comes the disadvantages. 1% risk for the procedure related pregnancy loss, does not screen for the open neural tube defect. 1 to 2% incidence of the genetic mosaicism, false negative results. Then comes the isoimmunization screening. Isoimmunization, antibodies produced against a specific RBC antigen as a result of antigenic stimulation with the RBC of the another individual. Then it comes the etiology, another fetal circulation normally separated by the placental barrier, but sensitization can occur and can affect the consanguinity current pregnancy or more commonly future pregnancies. Anti-Rh-AB produced by the sensitized Rh negative mother can lead to the fetal hemolytic anemia. Risk of isoimmunization of Rh negative mother with Rh positive ABO compatible infant is 16%. Then comes the what is the sensitization route? Maybe the blood transfusion, fetal maternal transplacental hemorrhage, and invasive procedure in the pregnancy, any type of abortion, labor and the delivery, and then comes any trauma like car accident and fall. Then on the side is basically Rh antibody titer. A positive titer indicates an increased risk of fetal hemolytic anemia. Then what's the investigation we do is basically indirect Coombs test at the first visit for the blood group, Rh status and antibodies. Then we do Kleehor-Betke test used to determine extent of the feto-maternal hemorrhage by estimating volume of the fetal blood volume that has entered maternal circulation. Then we do ultrasound for the fetal hydrops fetalis, and then middle cerebral artery Doppler are done to assess for the fetal anemia. If not available, then we check for the bilirubin is measured by the serial amniocentesis to assess the severity of hemolysis. Then we can also do choriocentesis, which is not the first line. Then on the side is basically standard dose of 300 μg of ROGAM sufficient for 30 ml of the fetal blood Give addition of 10 rogam for every ml of fetal blood over 30 ml. Then is prophylaxis. Exogenous rogam IgG binds to the Rh negative of the fetal cells and prevents them from the contacting maternal immune systems. Rogam gives to all Rh negative and antibody screen negative mother in the woman in the following scenarios. Which are the scenarios? Like routinely at 28 week we give, provide protection for at least 12 weeks. Then we are giving in the within 72 hours of the birth for a Rh positive fetus. Then in the invasive procedure like CVS or amniocentesis, any management of the ectopic pregnancy, any miscarriage or therapeutic abortion, and an antepartum hemorrhage or with the trauma. Then Rogam provides sufficient prophylaxis for 30 ml, and you can give like on the top of that anything. A clear Betke test or the flow cytometry can be used to measure the relative quantity of the fetal blood in the maternal circulation to determine if additional Rogam is indicated. Rh negative and AB screen positive follow mother with a serial monthly AB titers throughout pregnancy, ultrasound plus minus serial amniocentesis as needed. Rogam has no benefit as B cell sensitized antibody already in circulation. Then comes the treatment, basically failing biliary pigment warrants no intervention. Then we can do is basically indicated of the either unaffected or mildly affected fetus. Then intrauterine transfusion between 18 to 35 week gestation of the O negative packed RBCs may be required for the severely affected fetus. So if somebody is if a baby is or fetus is came out as positive and then it has a hydrops fetalis, then we need to give RBCs. Early delivery of the fetus for the exchange transfusion following 35 week gestation age. What is the complication that can occur? Anti-Rh IgG can cross the placenta and cause the fetal RBC hemolysis, like resulting in fetal anemia, congestive heart failure, edema, and ascites. So severe cases can lead to hydrops fetalis, like edema in at least 2 fetal compartments due to the fetal heart failure secondary to anemia. So in the fetal hydrops is basically edema that is caused by fetal heart failure. Or erythroblastosis fetalis, moderate to severe immune mediated hemolytic anemia. So two type of situation is happening, like hydrops fetalis and erythroblastosis fetalis. In erythroblastosis fetalis is basically hemolytic anemia, and hydrops fetalis is just like edema, like hydrops. Fetal surveillance, patient with the generally first risk fetal movement, basically quickening at 18 to 20 week gestational age in the pre-gravida can occur in 1 to 2 week earlier in the multigravida, can occur at 1 to 2 week later if placenta is implanted on the anterior wall of the uterus. If there is a concern about decreased fetal monitoring, the patient is counseled to choose a time when the fetus is normally active to count the movement, basically like usually recommended after 26 week. So if a woman came to you for the at the 26 week and she asked for what should I be doing at this particular time, so you can ask for to check the fetal movement. And then comes is like all high risk patients. So at 26 week we will check for the fetal movement, that movement should be checking it. All high risk patients should be advised to do fetal movement counts. So all high risk movements should be asked to do that. So what is happening, should experience at least more than 6 perceived movements in 2 hour period. If there is a subjective decrease in the fetal movement time, how long it takes to feel like 10 discrete movements. So it should be like at least 10 discrete movements. Laying on the left on the quiet setting may facilitate feeling subtle movement. If 10 movement take more than 2 hours, further requirement is indicated, and patient should present to the labor and the delivery triage for the assessment. So if it is taking more than 2 hours for the 10 discrete movement, then there is a problem. So we are asking for the labor and the delivery triage for the assessment. Okay, then is differential diagnosis of the decreased fetal movement. What could be the causes? Like maybe fetus is dead, maybe amniotic fluid is decreased, like oligohydramnios, and then maybe fetus sleeping cycle, and then maybe hunger or thirst, that's why fetus is lethargic and is not moving too much. Then comes the non-stress test, fetal heart rate tracing more than 20 weeks using an external Doppler to assess for the fetal heart rate and its relationship to the fetal monitoring. Indication is basically any indications of the uteroplacental insufficiency or suspected compromise in the fetal well-being. So normal NST2 acceleration more than 15 bpm from the baseline and the lasting more than 15 seconds in the 20 minute. So there should be 2 acceleration, should be for more than 15 bpm from the baseline and should be lasting for 15 seconds in 20 minutes. So the whole criteria is that this is basically normal NST. So if we say, is acceleration good or bad? So basically 2 acceleration is good, but deceleration is bad. Then there is a classification of intrapartum EFM tracing. Then we will be discussing this in the next session for sure. So that's about it. Thank you. See you guys next time. Bye bye.